right now.
Thanks for that.
Perfect. Okay, thanks to you. So we are going to follow a circular journey from the milestone of immunotherapy of cancer via bacteria, moving to the infectious field, the concept and our experience of trained immunity-based vaccines and the clinical trials and many observational studies in our experience with immune-deficient patients. And finally, back to the oncology field, which resumes very well this cancer immune deficiency paradigm. So first, I would like to pay tribute to William B. Coley, refer us to the father or the grandfather of immunotherapy, which he was a surgeon at the Memorial Hospital in New York, and he was deeply moved by the death of his very first patient due to metastatic bone sarcoma. And based on the observation of a spontaneous regression of a sarcoma due to erysipelas, he started to inject streptococcal bacteria and bacterial products directly into the tumors and refined his method, and he treated over 1,000 patients. And these Coley's toxins were not without controversy. He had numerous reports of successful outcomes in bone and also soft tissue sarcomas, but also questioning on the safety of his methods. And this pioneering work and legacy of William Coley was revitalized by his daughter, Helen Knotts, and she facilitated the collaboration with the immunologist David Auld at the Cancer Research Institute due to his work on non-specific immune stimuli like BCG that was capable of eliciting a robust anti-tumor immune response. So this approach that was particularly effective in treating bladder cancer has shown also promise, as the excellent talk of Christine, against a range of infections beyond this initial scope via the induction of trained immunity. Of course, there's recent advances that transform our understanding of the immune system, challenging this paradigm that only the adaptive immunity can produce immunological memory. And studies in plants and invertebrates without adaptive immune systems have shown that innate immunity can also confer resistance to reinfections. And this led to the pioneering concept of trained immunity that was introduced by 𝐒𝐥𝐸𝐬𝐻 and colleagues in 2011, which highlights how innate immune cells undergo long-lasting functional reprogramming after primary encounters. And we have arrived to the post-antibiotic era, that was the editorial of the journal Science, that started imagine that a world where routine surgery or chemotherapy is considered too dangerous because there are no drugs to prevent or treat bacterial infections. And there is a rise of superbugs that continues, making the pandemic of antibiotic resistance a major threat to global health. Pre-pandemic, in 2019, the estimation of drug-resistant infections was 700,000, while it would kill 10 million people worldwide by 2050. And infections, and particularly respiratory infections and diarrhea, rank among the top 10 causes of worldwide mortality, while antibiotics, of course, remain a crucial pillar of managing these infections. The rise of this antibiotic resistance necessitates alternative therapies. So non-antibiotic strategies are essential, such as vaccines or therapeutic monoclonals. And this problem, of course, is more marked in patients with recurrent infections, so immune deficient patients, in which the risk of antibiotic resistance and adverse effects is much higher and can be life-threatening. So here comes the concept of trained immunity-based vaccines designed to enhance the host resistance against a diverse array of pathogens, as trained immunity is generally triggered by pattern recognition receptors. These trained immunity-based vaccines are formulated with microbial structures that are that contain PRR ligands and can offer a broad protections, which is what we seek through two primary mechanisms. So boosting the non-specific effector response of innate immune cells like monocytes or macrophages or dendritic cells, and secondly, enhancing the activation state of dendritic cells to augment the adaptive T-cell responses to both specific and unrelated bystander antigens. So these trained immunity-based vaccines are especially useful when conventional vaccines are unavailable, and we have only 27 available vaccines, and also in scenarios that involve co-infections or recurrent infections in these at-risk populations. And I'm going to focus in some bacterial preparations, but mucosal vaccines that exploit the mucosa-associated lymphoid tissue. So the combined goal is to provide, as I said before, a broader and more effective protection against several infectious diseases, particularly those caused by pathogens entering through the mucosal site, so the portal entry. And our experience is mainly with
we cannot hear you anymore.
You're mute, Silvia, sorry.
Yeah, sorry. It was spontaneously, I don't know how it happened. So when did you lose me?
Only 1 minute before, don't worry.
Okay. So this slide or the one before? This slide is okay?
Yes.
Yes.
Okay, thank you. So our experience is mainly with these two preparations, MV130, which is a mucosal vaccine composed by 90% of gram-positive Staphylococcus, Streptococcus, and 10% gram-negatives of Klebsiella, Haemophilus, and Moraxella. And MV140 is composed 20% each of E. coli, Enterococcus, Klebsiella, and Proteus. So in respiratory infections, the 130, and urinary tract infections, 140. And these are strains heating activated, whole cell bacteria, and administer sublingual mucosa using pump spray, so two puffs per day for 3 to 6 months. And okay, now what happened now? Okay, so this MV130 in preventing respiratory infections has been substantiated through rigorous research in experimental viral infection models, and I want to highlight this because they are bacteria protecting against viral infections. And this MV130 confers heterologous protection in experimental models of respiratory viral infections, flu, vaccinia, and COVID, and also systemic fungal infections to Candida albicans. And it has been demonstrated that MV130 induces reprogramming of bone marrow progenitors in both mice and human monocytes in vitro. But of course, there are also potential risks, at least theoretically, in patients with excessive inflammation, atherosclerosis, or diabetes, or cardiovascular disease, or gut, or autoimmune diseases, or also neurodegenerative diseases. In 2011, we embarked on an observational study. It was a pilot study on, we recruited 17 patients suffering from recurrent respiratory tract infections. And each participant received a daily 2-puff daily administration of this MV130 over a 6-month period. And then we perform immunological evaluation at baseline and after 1 year, including CD4, CD8 T cells, and specific antibody responses, immunoglobulin levels, and B and T and NK cell subsets. And this immunization, as you can see here, was associated with a substantial decrease in frequency of recurrent respiratory infections, both upper and lower. You can see 30, 20, 80, and all over every patient. And when compared to the year prior to the starting the therapy, there was a significant reduction in the rate of infections, statistically significant. And as you can see below, an intriguing aspect of our study was that the observation of a patient who experienced something like 12 episodes of recurrent oral herpes, who had a dramatic decrease in episodes up to just 3 within the 6 months period following the treatment initiation. And this remarkable reduction in infections highlights this potentiality of this bacterial preparation, not only for bacterial infections, but also viral conditions, such as herpes. And in this 6 months mark, there was also statistically significant enhancement in proliferative responses, specific proliferative responses of CD4 T cells against the antigens in the preparation. And also, we also know that, as you can see here, and we also know that a notable increase in the total CD3 T cell count in CSF compared to control and compared to fetal hemagglutinin. And we are moving to the clinical trials, and recurrent wheezing in children represents a severe public health concern. And these wheezing attacks are mainly associated with viral infections, diverse viral infections, and lack effective preventive strategies. And this was a phase 3 randomized parallel group clinical trial. It was performed in 2 hospitals in Spain, in Valencia, to assess the safety and efficacy of MV130. And the subjects received this vaccine or placebo daily for 6 months. And then the primary endpoint was the number of wheezing attacks within 1 year, and the first dose, after the first dose, compared to comparing the vaccine with placebo. And the study included 120 children that below 3 years of age, with 3 or more episodes of wheezing attacks in the previous year. From almost 400 children, finally 120 were enrolled. 62 were assigned to the vaccine, and 58 to the placebo, and 59 and 54 completed the study. So the effectiveness in the vaccine in reducing the frequency of wheezing attacks was significant compared to the placebo, with a reduction of 40%. And there was a clear-cut increase in the time until the first wheezing attack. So the vaccine protected the 6 months following the discontinuation of the vaccine. There was also a reduction in the duration of these wheezing attacks. Also a significant decrease in both the symptom severities, or cough or dyspnea, and also a decrease in the need of medication in patients treated with the vaccine, respect to those receiving placebo. So this MV130 reduced the symptoms and the medication during the whole study period, but also very importantly, we didn't observe neither local or systemic reactions during the clinical trial. I'm going to mention also this second clinical trial to evaluate the efficacy, safety, and clinical impact of the MV130 in chronic obstructive pulmonary disease in 7 different hospitals in Spain. Again, a phase 3 placebo-controlled clinical trial in patients with moderate to severe COPD, at least 3 moderate exacerbations, which is a huge health problem, or 2 moderate exacerbations, including 1 hospitalization due to COPD. And the primary goal was to, again, to the number of exacerbations during the 18 months of follow-up to 12 months of treatment of receiving the vaccine and 6 months of follow-up. And what was observed is that this vaccine reduced the total number of acute exacerbations by 30%. What happened with recurrent urinary tract infections? With this, of course, this is a major health burden, mainly for women. And this was a pivotal study published in the New England Journal of Medicine that evaluated the efficacy of this MV140 for the prevention of recurrent urinary tract infections, a multi-center, double-blind, placebo-controlled, 240 women from 18 to 75-year-old in Spain and the UK. And they received this vaccine for 6 months. And the primary endpoint, of course, was the number of urinary tract infections in the 9-month period after 3 months or 6 months of intervention. And as you can observe here, there was a significant decrease in the episodes of urinary tract infections compared to placebo, with median episodes of 0 in women receiving these vaccines. And among women treated with placebo, 20% were free of infections, but compared to 56 or 58 in those treated for 3 and 6 months, respectively. And also in the right, there was an increased time free of infections with this vaccine to the first episode. And again, there was a very low registered adverse effects with respect to placebo. And there was another randomized double-blind placebo-controlled trial, but this time it was used also comparing with placebo, but to determine the impact of this vaccine in the personal burden of disease in women with recurrent urinary tract infections, because it represents a loss of quality of life. And compared with the placebo, this only 3-month vaccinated group improved in total, in general, and in physical quality of life scores. Only in social function, there was no impact shown. And there are many, several observational studies with these vaccines for recurrent urinary tract infections. And now I'm moving to present our work in immune deficiency and immune suppressed patients. We first conducted this clinical observational study in patients with common variable immune deficiency with recurrent respiratory infections despite adequate levels of immunoglobulins on treatment with immunoglobulin replacement therapy. But usually that require frequently antibiotics and can develop bronchiectasis and damage of the lungs that impacts very negatively their vital prognosis. And so these 10 patients received MV130 for 3 months, and we followed them for 1 year. And what we observed, that you can see here again, that patients treated with this vaccine showed a significant decrease in the infections rate. Every single patient, that was significant. Throughout the 12 months period, it's 70% remain free of infection, and 30% still have recurrences, but of course, very much decrease. And there was a decrease in the use of antibiotics and a scheduled outpatient visits to emergency department and of work absenteeism. And also we observed significant increases in the pneumococcus antibodies after 12 months, and an improved quality of life also in these patients, more than 50% of improve in their quality of life due to the lack of infections. And we performed, it was an observational, but we performed a pharmaconomic analysis that showed that there was a real impact on annual direct cost that decreased 4-fold with respect for every patient and year, with saving that range from 9,000 to 14,000 euros per patient year in terms of hospital healthcare and lost wages. And also the patients with systemic autoimmune diseases on active immune suppression. Infection, again, is a major cause of morbidity and mortality of these patients. For example, in systemic lupus erythematosus, you can see here 11% of death due to infections. And the same applied for rheumatoid arthritis. So we performed with the rheumatology department an observational study in systemic autoimmune diseases with recurrent respiratory infections or urinary tract infections. And we use MV130 or 140, depending on the type of infections. And the patients underwent these vaccines for 3 months, and we followed them for 1 year after the first dose. So 3 months under treatment and 9 months once discontinued. And we compare with respect to the prior year after the initiation of the vaccine. There was 41 of the 55 patients with systemic autoimmune disease, mainly rheumatoid arthritis, almost half of patients. Also lupus, mixed connective tissue disease, and different biologics, mainly anti-TNF alpha, rituximab, and also patients on conventional DMARDs, 100%. Again, we observe a significant decrease in the frequency of respiratory tract infections, upper and lower, in urinary tract infections, and in both patients that had both kind of infections. And again, antibiotic prescription and scheduled medical visits decreased significantly in all groups, and hospitalization also declined in patients with these recurrent infections. So again, the clinical benefit demonstrated was concomitant with significant increase in the production of specific antibodies, IgA and IgG, again, the preparation, but also again, Streptococcus, pneumococcus, and Klebsiella. And now I'm going back to cancer and related to the original idea of Bradley Collie. So infectious complications are a major cause of morbidity and mortality in B-cell hematological malignancy, 50% of mortality in CLL, 22% in multiple myeloma, and lower overall survival in non-Hodgkin lymphoma. And prophylaxis in these patients consists on antibiotics or gamma globulin when it is indicated. So again, we start to determine the clinical benefit of these vaccines in a cohort of hematological malignancy patients with recurrent respiratory tract infections. Again, with this MV130 for 3 months. And again, per analysis with respect to the year prior to the vaccine. Half of the patients showed a clear improvement, 40% only partial improvement, and only 1 patient low improvement, which was less than 25%. And this data correlated, as before, with the number of antibiotics, of emergency visits, and of hospitalizations, which what it means for patients not to be hospitalized. And again, regarding safety, we didn't observe any adverse events on our patients. On the other hand, we observe, again, a specific increase in IgA or IgG antibody responses to several of the bacteria that was contained in the preparations and on the whole preparations. So what's next? So we have finished just now the recruitment of a clinical trial in healthy individuals, young healthy individuals, to demonstrate in this population that is induce also trained immunity, not also in patients. And also in this field of we look at we take care of patients with this immune deficiency to hematological malignancy. We'd like to observe this potential dual role of protection against infections, but at the same time, if it could modulate negatively the cancer growth and progression. And with this, the conclusions are that these preparations of polybacterial mucosal vaccines confer heterologous protection. The clinical efficacy of this 130 in children with recurrent within episode, the symptoms and the rescue medications, but also in COPD. Of course, improve the quality of life of patients, which is our goal overall. And there are many observational studies in immune deficient patients and immunocompromised patients with recurrent infections that show that these trained immunity-based vaccines significantly reduce infectious rate, prescription of antibiotic, visits to emergency department, and hospitalization under active immune suppression. And most importantly, safety profile was excellent. And with this, I would like to thank you, of course, all the people that participated in this work, the hematology department, the rheumatology department, and also the clinical immunology department. So thank you very much for your attention.
Thanks a lot, Silvia, to give us such a wide portrait of MV 130 and 140. There are several questions regarding your work, maybe one question is about the duration of the effect of your two MVs. Did you have the chance to explore this question? How long does it last?
Yeah, for sure. This is a very good question. We observed that more or less the duration of this protection is 1 year. Very few cases, just 6 months. But we use one yearly for 3 consecutive years, and we then observe a long-lasting protection afterwards. So this 1 year maybe also is associated with this 1 year that 𝐒𝐥𝐸𝐬𝐬 is reporting about the duration of this trained immunity.
Okay, and maybe I had not realized that you need to administer the MV daily, is there no kind of chronic low-grade activation of the innate immune system, or does it actually allow a state of increased vigilance and responsiveness without inducing a state of activation?
Yeah, excellent question also. So it needs, these vaccines needs a repetitive paths, repetitive administration for 3 months every day, well, not exactly or not mathematically. And then what was observed is trained immunity induction, but also the production of IL-10. Maybe the mucosal via of these vaccines is essential for this balance between trained immunity and specific responses, but also tolerance induced by mucosal administration.
That was another question. Is the sublingual administration key in the effect of your mixture of inactivated bacteria? And let's say another, as respiratory administration, for instance, or another mucosal administration would also do the job?
For what has been described, and of course it's not my work, but it's essential, this sublingual administration, because it covers more than nasal or oral or directly mucosal. For example, I don't know, vaginal or rectal administration that were kept more local. So it's more a systemic effect in terms of training immunity and protective specific effects. So yeah, it seems that this sublingual administration is key.
Okay, and you used MV130 and 140, so the composition is slightly different, I guess. And what is the rationale behind the proportion of the different bacteria, or the identity of the bacteria? What can you comment?
Yeah, that's also excellent. Well, I don't know, because the company that produce make the experiments to decide which are the best composition for respiratory or urinary tract infections. But it followed distribution of the bacteria according to epidemiological studies. So, for example, 60% was caused by Staphylococcus or Streptococcus pneumoniae, and so it was kind of that. Not for the urinary, which is mainly composed by 75% of gram-negative bacteria, and 90% usually infections are by E. coli, but in the contrary, it's 25% all the 4 bacteria that causes the urinary tract infections. And it works. We have used also auto vaccines. So we make a culture of the bacteria, specific bacteria of particular patients, and we prepare auto vaccines. And these preparations are absolutely much more interesting and much more effective than these auto vaccines. So yeah, but of course there are many studies right now trying to use or to change the proportion and see what is the effect in terms of training immunity and in terms of cytokines. But from a clinical point of view, it works.
Yeah. There is a comment from Christine, the previous speaker, saying that you might have created something as beautiful as BCG. And of course, she would like to know if you see differences based on sex and differential effect between male and women in your trial.
Excellent question. I don't have this data because our data were observational studies, and the sample size didn't enable us to make this analysis. But I would ask for in the case of the ongoing clinical trials, what happened, because I don't think it's been reported like that. So maybe there was not a sex-dependent effect. But we don't have
and
data.
actually, yeah, maybe you should have a look.
There was
She
a
is
sex
like
bias. There was a huge sex bias.
And that's also striking. I've also noticed this, that it's like it seems that you don't have non-responders in a way. And for instance, there was a recent study showing that we are not all equal to respond to BCG for its training capacity. And it seems to depend on our state of our immune system in a way. And so what do you think here? Because it seems that it's not possible to push the BCG effect further, depending whether your state is or your cells are already trained in a way.
Thank you for this point, because sometimes having very good results is a problem, because of course most of the patients respond in the autoimmune, not always the same, and not all the same, but of course in general there was an excellent response, which is
but
sometimes problematic to respond.
I think the percentage of responder is high, but you also see differences between the patients. And so what do you know about them in terms of prior differences that would explain the differential effect, although that seems to respond well?
Yeah, when you look at the patients individually, you see that there are differences. And also you can personalize these vaccines. For example, we see some patients with bronchiectasis and Pseudomonas colonization, which is very difficult to treat in the clinical practice. And we have personalized sometimes these preparations with a percentage of Pseudomonas. And it has worked in general very well. But of course, each patient is different. And the heterogeneity of human disease is clear also. But the results are very good.